So we now are going to welcome back our live stream audience, and so thank you for waiting patiently, those of you that have been waiting over the break. And so first up we have Dr. Yoon Hi Cho, who's going to present work from Soleno. Thanks very much.
Hi, it's a real pleasure to present on behalf of Soleno Therapeutics. I'm a paediatric endocrinologist at the Children's Hospital at Westmead. By way of background, Soleno was a partner organisation in a research grant that I submitted earlier this year involving DCCR. I have no other disclosures. How do I... Is that it? Okay, so DCCR is a tablet formulation of a choline salt of diazoxide. And diazoxide is a medication very familiar to paediatric endocrinologists. It was chosen for its solubility and its formulation to extend absorption through the gastrointestinal tract. And as you can see on the diagram to your left or right, it has a very stable intraday circulating drug levels, and studies have shown that there's a strong relationship between circulating drug levels of DCCR and its therapeutic response. So how does it work? DCCR, as with diazoxide, works on the potassium ATP channel. And paediatric endocrinologists are familiar with this through the use of diazoxide in congenital hyperinsulinism on its action at the level of the beta cells in the pancreas to reduce insulin secretion. But in Prader-Willi Syndrome, the postulated action level of action is at the hypothalamus, at the neuropeptide Y, Gucci peptide, related peptide and GABA neurons to impact hyperphagia, and possibly through vagal neurons and adipocytes. So the phase 3 clinical trial is outlined here. It was a multi-centre randomised double-blind placebo-controlled trial conducted in the US and UK. The patients were randomised in a 2-to-1 ratio with a total of 127 participants. There were 85 in the DCCR arm and 42 in the placebo arm, and this was recruited from May 2018 until January 2020. So the mean age was 13 and a half years. So moving on to the primary and key secondary endpoints, you can see that there was a more negative, so decline in hyperphagia scores in the DCCR group, but this did not reach statistical significance despite significant differences in the clinical global impression scales and the body fat mass index on DEXA. However, the last part of the DCCR trial actually spanned into the COVID lockdown period, and as everyone in this room will agree, this involved significant changes in the home environment and postulated that there would be behavioural impact on not only participants but the caregivers. So excluding the data from March 2020, looking at the pre-COVID data, there was a statistically significant difference in favour of DCCR in hyperphagia and all the other secondary outcome measures. Looking at the behavioural endpoints, again looking at the pre-COVID data, there were significant differences in the PWS profile domain scores, as you can see there, in aggressive behaviours, anxiety, and also in the DBC2 questionnaire as well. And this was looking at the total score, the communication disturbance, and the social relating. Looking at hormonal and biochemical parameters, there were significant or favourable changes in the hormonal parameters, including decreased ghrelin, so ghrelin's commonly known as the hunger hormone, decreased leptin, decreased insulin, and increased adiponectin. So these were promising results and followed by the open label study. So the C602, or the open label phase, was an ongoing extension study of DCCR in participants who completed the Destiny PWS trial. In parallel, as a contemporary cohort, PATH is a natural history cohort sponsored by the US Foundation for Prader-Willi Research. And there were 650 active participants who completed questionnaires online every 6 months, including the same parameters of the hyperphagia questionnaire and the PWSP questionnaire by caregivers of people with PWS. Importantly, participants in the natural history cohort were matched for the same inclusion criteria as the DCCR cohort. So to your left is the open label study phase result. And as you can see, there was ongoing decline in the hyperphagia score, which was statistically different from baseline, and this was sustained up to 52 weeks. And compared to the natural history cohort, there was a significant difference in the hyperphagia scores, again in favour of DCCR. And this was significant at 26 and at 52 weeks. Looking at the PWS profile, in behavioural change, there was significant favourable changes in all the parameters, including aggressive behaviours, anxiety, compulsivity, depression, disordered thinking, and rigidity. And compared to the natural history cohort, again, the DCCR cohort demonstrated a significant favourable change in the behavioural parameters. Looking at endocrine and hormonal measures, there was decreased leptin, decreased insulin, decreased HOMA-IR, and that's a measure of insulin resistance, and increased adiponectin. And these parameters are all in favour of positive weight homeostasis. So the FDA stated that additional control trials were necessary to support a new drug application submission. So in June 2022, the FDA acknowledged that data from a proposed randomised withdrawal trial would be sufficient, potentially sufficient. So randomised withdrawal only included subjects who were currently enrolled in the C602 with no new subjects, and you can see that timeline there. So looking at the primary endpoint of hyperphagia, there was a statistically significant difference in favour of DCCR in those who stayed on DCCR versus those who were taken off. And I think this is very dramatically seen and visually here, where the green line represents the participants who stayed on DCCR, and they maintained the hyperphagia score from baseline, whereas the blue line shows those who were randomly withdrawn, and they demonstrated a significant increase in the hyperphagia scores. And just breaking down the hyperphagia questionnaire, that you can see that each of the questions showed significant differences. So, for example, how upset were you when you were denied food? Because you probably can't read it. How often bargain for food? How often forage through trash for food? How often does the person get up at night to food seek? And so in all the questions, there was a significant difference. So in subgroup analysis as well, there was a significant difference from baseline for male and females, those with lower baseline HQCT scores and those with more significant hyperphagia at baseline. and by country, just looking at different management or environmental factors as well. Looking at the secondary endpoints at week 16, there were trends showing worsening with placebo, but these were not statistically significant. And again, the behavioural endpoints were not significantly different despite a trend. In terms of body weight and BMI, there were significant differences in with favouring DCCR. So in summary, the randomised withdrawal period showed highly statistically significant change in the primary endpoint and the objective endpoints, which led to the FDA submission. Looking at the DCCR safety profile, Soleno has now had more than around 100 patients treated for more than 1 year, and the safety profile is generally consistent with prior experience with DCCR and the known profile of diazoxide. And as, again, paediatric endocrinologists will be well aware, the most common adverse effects of diazoxide and DCCR are hypertrichosis or too much body hair, peripheral edema or puffiness, and hyperglycemia. Most adverse events were grade 1 or 2 in severity or mild to moderate, and there were no grade 4 or life-threatening events or higher. And all these adverse effects were usually self-limiting and some needing dose adjustment. There was only one serious unexpected adverse event in an aggression in a patient with a known psychiatric history. So for those of you who want to read a bit more about the studies, they have been published in the last year and a half, and I've just put quick reference there. And the most recent randomised withdrawal trial was presented at the recent ENDO meeting. Thank you. I'm happy to take any questions during the break. Yeah.